On page 155 of the book, there is a lovely little box, box 7.1, with just a listing of the extrinsic and intrinsic hand muscles. So the extrinsic muscles are the ones that have proximal attachments outside of the hand. They cross the wrist, and then they have distal attachments in the hand. The intrinsic muscles have proximal and distal attachments both in the hand. So we're going to talk about the intrinsic muscles just as groups, functional groups. We're not going to talk about their individual origins and insertions. The extrinsic muscles, we will talk about them, and they form themselves into nice little groups as well. So we're just not going to get too crazy with it. So you should know the prime movers, but in functional ways. Identifying positions of active and passive insufficiency for two joint muscles. We are primarily going to talk about this with the idea of tenodesis. So we'll talk about what tenodesis is. You should know which groups of muscles make up the thenar eminence and the hypothenar eminence, which is like the meaty part at the base of your palm. And I just want you to know the names of the muscles. You don't have to know their origins and insertions. I just want you to know the name of the muscle that has a combined action that is described as tabletop position, which is this: holding a sandwich, holding a book, holding a stack of paper, something like that. And when we do manual muscle testing, we do that kind of grip so we don't dig our fingers into people. So that's important. The anatomical snuff box is a little feature on our hands, and I just want you to know the names of the muscle tendons that are involved in forming the anatomical snuff box. So the interesting thing about the hand, this is sort of more neuro, but I'm just going to go there. I'm going to go right to neuro. There is a representation of the brain, of the motor and sensory areas of the brain, that's called the homunculus. This is the motor homunculus, and it shows the somatotopic representation of body parts, meaning there's a one-to-one correlation between areas of the brain and areas of your body for sensory and for motor function. Look how big the hand is compared to the whole lower extremity and trunk, and look how big the face is. So the face and the hand are disproportionately represented in the motor and sensory areas of the brain. There's a huge proportion of the brain that's dedicated to controlling the hand. Really, I just bring this up to note how important hand motion is to us as human beings. And we're going to talk more about it in other classes, but we're just kind of dipping our toe in the water right now. So the hand innervation, it has this little picture which makes it easy to remember. The radial, median, and ulnar nerves innervate the skin, joints, and muscles of the hand. Normal sensory innervation is essential for the protection of hand against mechanical and thermal injury. So it tells you to take your hand out of the fire or, you know, don't roll your fingers up in the window, something like that. Persons with peripheral neuropathy are more vulnerable to injury because they don't have that protection. So the radial nerve is the dorsal surface of the hand, the median nerve is the thumb half, and the ulnar nerve is the pinky half, if you want to think of it that way. So the extrinsic flexors of the digits are the first set of muscles we're going to talk about. So there's three of them: Flexor Digitorum superficialis, Flexor Digitorum profundus, and Flexor pollicis longus. So two of them flex the fingers and one of them flexes the thumb. And the two that flex the fingers, they separate into four separate tendons that go through the carpal tunnel. So the 9 things that go through the carpal tunnel, number 1 is the median nerve. And then we have 8 tendons, 4 from the digitorum, Flexor Digitorum superficialis, and 4 from the Flexor Digitorum profundus. And their names, superficialis and profundus, one is superficial and one is deep. Like, how easy could that be? And interestingly enough, just like the wrist flexors, they all originate on the medial epicondyle of the humerus on the common flexor origin, and some parts of them on the palmar surfaces of the radius and ulna. So easy, hopefully. And the ones on the thumb side get the median nerve, and the ones on the pinky side get the ulnar nerve. So the Flexor Digitorum superficialis, it has two heads proximally, and then it splits distally into 4 digits. You can palpate the tendon medial to the palmaris longus. So the palmaris longus, if you have it, if you're the 79% of people that have it, if you go medial, which is towards the pinky side, and flex your fingers, you'll feel that tendon popping out. So it's that medial epicondyle common flexor tendon, and then the other head originates on the coronoid process and partially on the radius. So the insertion is the sides of the middle phalanx of the 4 fingers. So it not only splits into 4 and then 4 tendons and then goes through the carpal tunnel, then each of those 4 tendons splits into 2 to go to either side of the middle phalanx of all 4 fingers. So it flexes the proximal IP joints and the metacarpal phalangeal joints of the fingers. And it also flexes the wrist, gets the median nerve. So it splits in 2. And the rhyme that I remember this, the superficialis splits in 2 to let the profundus go on through. So the Flexor Digitorum profundus runs through the split of the Flexor Digitorum superficialis. And it's the only muscle that flexes the distal IP joint. So it originates on the anterior ulna and interosseous membrane, and it inserts on the distal phalanx of the 4 fingers. So the superficialis splits in 2, goes to the middle, either side of the middle phalanges, and the digitorum profundus goes on through to go out to the distal phalanx of those 4 fingers. So it flexes the metacarpal phalangeal joints, the proximal IP joints, and the distal IP joints. It's the only muscle that flexes the distal IP joints. The lateral half gets the median nerve, and the medial half gets the ulnar nerve. Okay, so the thumb half gets the median nerve, and the pinky half gets the ulnar nerve. Okay. So the flexor pollicis longus is the only muscle that flexes the IP joint of the thumb. It also originates on the anterior radius and interosseous membrane, just like the Flexor Digitorum profundus, and it inserts on the distal phalanx of the thumb. So it's like the thumb's version of the Digitorum profundus. It flexes the carpometacarpal, metacarpal phalangeal, and IP joints of the thumb and wrist, and it gets the median nerve because it's on the thumb. Everything on the thumb gets the median nerve. So there are flexor pulleys embedded in the fibrous sheath around the digit. It surrounds flexor tendons and gives them nutrients and lubricates them. With tendon injuries, you might get adhesions and they get stuck, and that's called trigger finger. So you don't really need to know that. It's just like interesting information about the flexors. So with passive finger flexion, you can get passive finger flexion with tenodesis action. So the extrinsic flexors of the digits cross over the anterior side of the wrist, and the wrist position alters the amount of stretch that's placed on the muscles. So if you stretch the multi-articular muscle at one joint, it creates passive movement at another joint, and that's referred to tenodesis. So just try it. Relax your hand, and don't try to flex your fingers, but extend your wrist, and the fingers will naturally go into flexion. So if you lose innervation for your finger flexors because of an injury, you can regain a functional grasp by extending your wrist. So there's a video in the module that I put where it shows a guy with a spinal cord injury, and he's talking about how he uses that tenodesis action functionally to have a functional grip. And then when you flex your wrist, the fingers relax and you let go. So gripping is holding on and letting go. So just try it, relax your fingers, extend your wrist and your fingers will naturally flex. And then flex your wrist and your fingers will naturally extend a little bit and let go. So if you don't have full finger flexion innervated, you can have a functional grasp using that tenodesis action. Pretty neat, huh? So the extrinsic extensors of the finger, the extensor tendons don't attach directly to the phalanges, but there's an extensor mechanism on the dorsal side of the fingers. The proximal end of that extensor mechanism is called the dorsal hood, and it wraps completely around the metacarpophalangeal joint. The extensor mechanism is the primary distal attachment for the extensor muscle tendons and the intrinsic muscles of the fingers. So that, I mean, that's all you need to know about that. It's just that they attach to that extensor mechanism. So the extensor digitorum, it's easily palpable on the dorsum of your hand. You can even see the tendons through on a lot of people's hands. I have very tendony hands. You can really see them on mine. It is the common extensor tendon on the lateral epicondyle for the origin. It inserts on the base of the extensor mechanism and the base of the proximal phalanx of the four fingers, and it extends the fingers. That's its job. So if you want to fling water off your hands because they're out of paper towels in the bathroom, you need your extensor digitorum. It gets the radial nerve, like everything on the posterior side of the wrist and hand gets the radial nerve. Extensor indices, it's the it attaches to that extensor expansion. It is on the posterior side of the distal ulna in the interosseous membrane for its origin, and it blends with the index tendon of the extensor digitorum. You can palpate those two separate tendons, extends the index finger. So what I say is that this is the one for making your point. It has its own muscle for making a point or getting in someone's face or going up to the umpire and saying, that was clearly a ball, not a strike. You need your extensor indices. And it gets the radial nerve because it's all the extensors get the radial nerve. The extensor digiti minimi, it's the same, it's the extensor just for the little finger. So it's the ulnar side of the belly of the extensor digitorum. So it actually inserts on another muscle rather than inserting on the bone. And it blends with the little finger tendon of the extensor digitorum. You can palpate the two separate tendons going into your little finger, and it extends the fifth finger. So we have a little muscle just for that. Isn't that cool? I don't know why I love that so much, but I do. I just think it's neat. So that's our little pinky finger extender. So when you think about the motion of opposition and reposition, the little finger mobility is really important for that, for gripping and stuff. So functionally, it makes sense that we have an extra muscle for that. So the extrinsic extensors of the thumb are extensor pollicis longus and extensor pollicis brevis, and abductor pollicis longus is involved in that as well. The tendons of those three muscles, extensor pollicis longus, extensor pollicis brevis, and abductor pollicis longus, make up the anatomical snuff box on the side of the wrist. So this photograph has a really good picture of it. By extending and slightly abducting your thumb, you can see it on your own hand. The tendons attach to different regions of the dorsal side of the thumb, and a lot of them have multiple actions, but you know, since not a lot of people use snuff these days, since the 1800s or over, you could catch water in it if you're in the desert, drink out of it. I don't know. But anyway, that's a good way to locate those tendons. And the floor of the anatomical snuff box is the scaphoid bone. So if you want to find your scaphoid, it's the floor of the anatomical snuff box. So the extensor pollicis longus originates on the posterior ulna and interosseous membrane. It's on the posterior side, it gets the radial nerve, and it inserts on the distal phalanx of the thumb. So it extends the CMC, MCP, and IP joints of the thumb, gets the radial nerve. So it's your hitchhiking muscle. Extensor pollicis brevis, of course, helps the extensor pollicis longus, but it only extends the carpometacarpal and metacarpal phalangeal joints of the thumb. It does not extend the distal IP joint or the IP joint of the thumb. So it inserts on the, it has this a similar origin, but it inserts on the proximal phalanx of the thumb instead of the distal, and it gets the radial nerve because it's an extensor. Abductor pollicis longus abducts the whole thumb. Even though it inserts on the metacarpal, it just drags the rest of the thumb with it. So its origin is on the posterior radius, ulna, and interosseous membrane. So all of these have similar origins. They're all on the posterior radius and ulna and interosseous membrane, and then their insertions vary what they do. So the abductor pollicis longus inserts on the base of the first metacarpal, and that way it moves the whole thumb with it. It does abduction and extension of the carpometacarpal joint of the thumb, and it gets the radial nerve because it's on the extensor side, so it gets the radial nerve. The intrinsic muscles of the hand, you don't have to know all their origins and insertions, just to kind of know where they live and what their names are. The thenar eminence is the little bunch of muscles that is right at the base of your thumb. It includes the abductor pollicis brevis, the flexor pollicis brevis, and the opponens pollicis. They all insert on the transverse carpal ligament and adjacent carpal bones. The hypothenar eminence is the little bit of muscle that's at the base of your pinky finger. The muscles of the hypothenar eminence are the flexor digiti minimi, the abductor digiti minimi, and the opponens digiti minimi. So look at these lists. With the thenar eminence, it's the flexor, abductor, and opponens of the thumb. With the hypothenar, it's the flexor, abductor, and opponens of the little finger. So those are fairly easy to remember. The adductor pollis is a big triangular muscle that sort of fills in the web space between your thumb and your first finger. So the adductor pollicis, not strangely enough, adducts the thumb. The lumbricals and the interossei are the intrinsic muscles of the fingers. So the lumbricals, they don't attach to the bone distally, but they attach to the extensor mechanism, and they flex the MCP joints and extend the PIP and DIP joints. So you get that tabletop position. So the lumbricals are the muscles that are responsible for that tabletop position. So I think of it as you're holding a sandwich, you're holding a book, you're holding a stack of papers, or you're holding somebody's arm to do manual muscle testing so you don't flex your IP joints and dig your fingers into their hand. So that lumbrical grip, we call that a lumbrical grip, it keeps you from digging your hands into something. So when you're holding a sandwich, you don't want to dig your fingers into the bread, you want to hold it with a lumbrical grip so you don't crush your sandwich, right? So flexion in the metacarpophalangeal joints and extension in the interphalangeal joints. That's what gives you that lumbrical grip. The interossei are named for their location between the metacarpal bones. There are palmar and dorsal sets. All 8 are innervated by the ulnar nerve, which is deep in the hand, and their primary function is to and adduct the fingers. So a good way to remember them is the digital interossei abduct the finger, DAB, dorsal abduction. Palmar adduct the fingers, PAD, so dab and pad. Dorsal interossei abduct the fingers away from the middle digit, and palmar interossei adduct the fingers towards the middle digit. Okay, so that's all you need to know about them, is their function. So we talked about this a little bit in the wrist section, how making a strong fist requires equally strong synergistic activation from the wrist extensor muscles. Wrist extensor activity, if you palpate the dorsum of your forearm while you're making a fist, you'll feel those wrist extensor muscles pop. So put your hand on the dorsal side of your wrist and make a strong fist, and you'll feel those wrist extensor muscles pop right out. If your wrist extensors are damaged or paralyzed, attempts at making a fist result in wrist flexion and finger flexion, which is a weaker grip. Okay, so that wrist extension, synergistic activation is super important for a strong grip. So this is just a picture that has common deformities. Deformity of the hand is often caused by disease or trauma that disrupts the balance of the forces around the joints. So there's typical hand deformities with rheumatoid arthritis, with severe rheumatoid arthritis, ulnar drift, where the fingers kind of tend to go towards the pinky, swan neck, which is where the proximal IP joint is hyperextended and the distal IP joint is flexed. You can't even do it with a normal finger, and I imagine it's painful. The boutonniere deformity is the opposite, where the distal joint is hyperextended and the proximal joint is flexed. So I'm not really going to quiz you on those individual deformities, but suffice it to say, if the forces around your joints in your fingers are disrupted by disease or trauma, it can cause significant deformity in your hands, which is going to affect your function. Years ago, I worked with a lady who had severe hand deformity from rheumatoid arthritis, and she was the switchboard operator at the hospital where I worked. And so her hands were quite gnarled and deformed, and she would, punch the buttons on the switchboard with her fingers. And she told me one time, she said, if you ever start having problems with arthritis in your hands, go to the doctor right away, because there are things they can do. And actually now, that was a long time ago, and there wasn't as much they could do then, even though there was some action they could take. Now there's even more that they can do. There are medications that treat rheumatoid arthritis. And so she said, don't let it get as bad as my hands are. If you have problems with your hands, go see someone about it, because it's really important. So the function of our hands is really important. It's something that affects our day-to-day life in a very profound way. So the joints of the hand are organized into 3 sets of articulations: the carpometacarpal joints, the metacarpophalangeal joints, and the interphalangeal joints. The metacarpophalangeal joints form the base of each digit. That's our knuckles. The IP joints only flex and extend. They're little hinge joints. The other potential planes of motion are blocked off by the bony fit of the joint and the connective tissues. So simultaneous extension of all 3 joints of the fingers requires coordinated interplay among muscles.